One and all. This is Dr. Vidyut Banerjee, representing Spice Route, Haryana, along with Dr. Atul Krishna Goel. He'd be presenting an interesting case of PUO in a patient of rheumatoid arthritis. So let's hope we can all learn from this presentation. Over to Dr. Atul.
Good evening, everyone. Myself, Dr. Atul Goel. I'm third year DNB resident from Artemis Hospital, Gurugram. Today, I'm presenting a interesting case on pyrexia of unknown origin in a patient of rheumatoid arthritis. Thank you so much, Dr. R.K. Prasad sir, to be present as the faculty today. I shall start my case presentation. So my patient is Mr. XYZ. He's a 63-year-old male, resident of Mahendragarh, Haryana, and he's a retired government official. He presented to Artemis Hospital with chief complaints of fever of 8 weeks duration and easy fatigability, same of 8 weeks duration. The patient was in his usual state of health about 8 weeks back when he started having fever. The fever was insidious in onset, recorded between 99 to 100 degrees Fahrenheit at home every day during evening hours, and was not associated with any chills or rigors. Fever was either relief on its own or the simple OTC medications, paracetamol tablets. Fever was also associated with easy fatigability, as he noticed in doing his routine day-to-day physical activities. Fever was not associated with any headache, altered sensorium, cough, difficulty breathing, chest pain, palpitations, abdominal pain, altered bowel habits, burning micturations, or rashes. Patient also did complain of significant weight loss. He had lost around 15 kgs of weight from April 2020, March 2022 to April 2023. It was 80 kgs during the March, and then he was around 65 kgs in April 2023. Out of those 15 kgs, he had lost around 9 kgs in the last 3 months only. He denies any intentional weight loss or any history of reduced appetite, recurrent vomiting, diarrhea, or any other significant change in eating habits or physical activity. So the patient's bowel and bladder habits were normal on presentation. In his past history, patient is a known case of rheumatoid arthritis. He was diagnosed in the month of April 2019. He was positive for rheumatoid factor and anti-CCP antibodies. Patient was started on methotrexate 15 mg once weekly with folic acid tablets daily. And he was compliant to the medication for next 10 months or so, but then lost to the follow-up. Around in the month of February 2022, he returned to the rheumatology department with a flare of his rheumatoid arthritis. At that time, he was not compliant to his medication and thus was restarted on a lower dose of methotrexate 7.5 mg once weekly with the folic acid doses. During his current presentation, patient had not been taking his folic acid tablets with methotrexate since last 1 year. He had stopped taking methotrexate also just 2 months before his presentation. Patient has no history of diabetes, hypertension, bronchial asthma, tuberculosis, COVID-19 disease, or any other illnesses requiring hospitalization or any other prolonged treatment. Patient has no history of any surgical procedure. In his personal history, patient is a vegetarian by diet and denies use of alcohol or tobacco and use or abuse of any recreational drugs. He has no history of blood transfusions, IV drug abuse, or any promiscuous behavior. Patient is a upper middle class as per the modified Kupuswamy scale. His family history is that he's been married for last 40 years and has 2 children, 1 male and a female. There is no history of any similar illness in his family. In his clinical examination, there were not much significant findings. On his general physical examination, patient was conscious, oriented to time, place, and person. On measuring his vitals, the pulse was 78 beats per minute, normal volumic, regular rhythm. The character of vessel was normal, and there was no radial or radiofemoral delay. His blood pressure was recorded to be 100 by 68 millimeter of mercury, and the pulse pressure was normal. His respiratory rate was 14 cycles per minute, and it was abdominal thoracic. There was no apnea, no breathing difficulty. Patient was afebrile presentation, and the oxygen saturation was found to be 97% on 2-minute only. On the rest of the examination, there were no other findings. There was just pallor. There was no tears, no sinuses, no clubbing, no reports were palpable. There was no raised GBP or no edema to be found. Significant findings were not either observed on the systemic examination. Patient higher mental status were completely normal. He had no neurological deficit, power by 5/5 in all the 4 limbs. For his CVS and respiratory examination, chest was exposed, which showed no visible scars, no veins, no palpation or percussion finding that was significant. On auscultation, the respiratory sounds were completely normal. S1, S2 was heard, which was okay. And there were no other added sounds on auscultation either. His abdominal examination also revealed none of the visible abnormalities, no organomegalis. There was no visible distension or any abnormal bowel sounds. They were perfectly normal. To summarize my case, Mr. XYZ is 63 years old, presented to the internal medicine department of Artemis Hospitals with his chief complaints, low-grade fever and easy fatigability since last 8 weeks. Patient also complained of around 15 kgs of weight loss in 1 year, with around 9 kgs of weight loss in last 3 months. Patient in known case of rheumatoid arthritis, previously taking methotrexate once weekly without folic acid tablets and currently off medications. Patient had pallor on examination and there were no significant other findings, including nodes. The differentials that we were able to make out of the history and clinical examinations included tuberculosis or other non-tubercular mycobacteria, malignancies like lymphoma, multiple myeloma, and the retroviral disease, any other autoimmune disorders apart from rheumatoid arthritis. And there was pallor. We thought of anemia due to any secondary cause like chronic disease that was identified or the drug induced. He was taking methotrexate also. Less likely diagnosed was also thought of endocarditis. On investigation, his routine investigation showed a normal kidney functions and liver functions. His complete blood count though did show decreased hemoglobin of 7.9. He was anemic and he had thrombocytopenia also with 93,000 platelets on presentation, which did fluctuate during his hospitalization. His blood smear, peripheral blood smear, was also suggestive, surprisingly, of autoimmune hemolytic anemia. The smear showed Kroll type agglutinins. A DCT was done further, DCT, ICT both were done further. DCT was positive, but 3+ positive result was obtained, while the indirect Coop test was negative. For further examining the patient, we did hepatitis B, C, and HIV 1 and 2 markers, which came out to be negative. Basically, all his basic blood culture reports and everything was not suggestive of any particular etiology. His baseline investigations continued to be negative, so we further thought of doing a radiological examination. A contrast-enhanced CT for chest and abdomen both were performed, and the only significant finding we could find was diffused splenomegaly. The spleen was of 16 centimeters, almost 30% of the normal, and liver was 17 centimeters. There was also an evidence of pulmonary emphysema, which was a significant finding. Since the cause was not still ascertained by us, we finally went to do a bone marrow biopsy for the patient for the evaluation of anemia, and also that the peripheral blood smear was showing cold antibodies, which was not explained by his rheumatoid arthritis. Further, on follow-up, the biopsy reports revealed growth of histoplasma capsulatum. He was started on itraconazole 200 milligrams per orally twice daily, and further followed. This was a very surprising case for us. We had not encountered any other immunocompromised patient like this. He did not even look immunocompromised to us, and we had found a rare disease of histoplasma capsulatum for us. So, a brief discussion about the disease itself. So, histoplasmosis is an infection caused by a fungus called Histoplasma capsulatum. The essential features involve that is a dimorphic mold. In the environment, it remains as a mold forming tuberculate microconidia. It's known as a strip's wheel appearance. In body temperature, as soon as it enters the body, it forms intercellular uniform small oval cysts with really narrow based budding. In immunocompetent patients, it usually is a asymptomatic or tuberculous-like illness with necrotizing gliomas. Though in immunocompromised patient, it is a disseminated disease with a poor prognosis. Epidemiology, the histoplasmosis, though not known much to us, is quite common in the world as well as in India. It is a global disease endemic to 6 continents, including North and Central America, Eastern and Southern Europe, parts of Africa, Eastern Asia, and Australia. In India, also from 1954 through 2017 only, 144 cases were recorded, ranging from West Bengal, Assam, Bihar, Delhi, Haryana, Punjab, and Uttar Pradesh. As you can see, this is basically the distribution of histoplasmosis in India. Usually the authors which show the books which have written, they show these areas of common histoplasmosis that they are on the left side. But we can see on the right side that is much more common in India than we see in our books. Then again, what causes this disease is usually it is a soil-based disease. It's usually found in material like digging in soil, chopping wood, where there are usually birds or bats dropping. The bats dropping thing might not be such common in India, but birds, including chickens and all, have been found to be very common cause for histoplasmosis. Cleaning chicken coops, exploring caves, cleaning, remodeling, tearing down old buildings, all of these have significant exposure of people to get exposure basically to the disease. For a little bit of pathophysiology, these fungus spores, when present in soils, are inhaled by the exposed individuals. As they enter the respiratory tract, the alveolar macrophages and neutrophils are unable to clear the infection. The yeast persists within the macrophages and gradually spreads to the lymphatics. If the patient is immunocompetent, there is no problem there. The T cell activation promotes the effective granular formation and the disease stays contained. But if the patient is immunocompromised, organism continues to proliferate, and within the reticuloendothelial system, it disseminates. As you can see in this diagram, we can show that in the environmental form, there are macroconidia, tubercular macroconidia, the birds and bat droppings, the wood chopping and all can be inhaled. The spores can be inhaled by us. They enter the lungs, where they go to the lymphatics, then they disseminate to the blood. So the clinical features, we come to the clinical features now. They are basically divided into 3 categories: pulmonary histoplasmosis, mediastinal histoplasmosis, and progressive disseminated histoplasmosis. Starting with the pulmonary one, which is the most common also, the patient, especially if immunocompetent, usually remains asymptomatic, or the disease is usually a self-limiting respiratory illness. Acute disease, if it occurs, is usually characterized by fevers, chill, dyspnea, and cough. Subacute disease, it presents as a persistent community-acquired pneumonia despite standard antibiotic treatment. Chronic disease, whereas it presents with productive cough, low-grade fever, weight loss, and night sweats, just like our case here. The mediastinal histoplasmosis They are mostly asymptomatic, especially if it is adenitis, self-limited, and with fever and retinopathy. If there is a granuloma formation, the cluster of necrotic lymph nodes, oval, paratracheal, and subcarinal, are coalesced into a semi-liquid columnar mass that has caseating necrosis also. In fibrosing mediastinitis, dense fibrotic mass with obstruction of pulmonary vessels or EFP can be seen. Finally, we come to what we saw in our case, progressive disseminated histoplasmosis. Immunocompromised patients are at increased risk for this. They present with fever, fatigue, night sweats, dyspnea, and weight loss. Dissemination may be to the liver, spleen, gastrointestinal tract, and bone marrow, where we found in our case, organism in our case. So histoplasmosis, as we did also suspect in our case, can have following differential diagnosis. It can be tuberculosis infection, other mycobacterial diseases. It can be malignancy like lymphoma, multiple myeloma, etc. There can be mycoplasma infections, blastomycosis, and coccidiomycosis that are not so common in India, or sarcoidosis. On evaluation, patients should be always asked for a history of exposure. That can specifically pinpoint in sporadic cases, with the cases not that endemic. Cleaning basements, house attics, construction work, working with soil are some of the most important points of exposure. In laboratory investigations, complete blood count can show bone marrow suppression like pancytopenia, neutropenia specifically. Imaging CT and all can show healed granulomas in lungs, spleen, or liver. A direct microscopy taken through a biopsy or a FNC can show small, uniform, narrow-based burning yeast cells, which is the form in which it remains in the host cells intracellularly in cluster with the host cell. Bronchoscopic lavage usually not performed if there is nothing found like in our case, but even it is done, it is unlikely to be positive. But it can be done to exclude any other concomitant pathologies which we may suspect, like tubercular and all. So next, when we move towards specific tests for this, they are complement fixing antibodies titer, which when 1 is to 32 or a 4-fold rise in titers, it is used to diagnose an acute infection. Complement fixation antibodies are though less specific than an immunodiffusion assay, which tests for presence of M and H precipitin bands. Western blots and enzyme immune assays are also used. Patients with disseminated histoplasmosis, they have high level of histoplasma antigenuria. The antigen can be detected in their urine, and level is used for diagnosis and also for the prognosis, the response to the therapy. Finally, the absolute diagnosis can also be made with cultures, which is usually, as in our case, was found in a blood culture. They show characteristic large tuberculoid macrochoridia. This is the slide of our own patient, the microscopic slide of our own patient. You can see both the Simpson stain and the Gram stain here. And as you can see marked by the red arrow, these are the large tuberculoid macrochoridia, which are basically the markers of histoplasmosis. This is the organism itself. And as you can see, this is a lot of it. This patient had a lot of disseminated histoplasmosis. So, as I said, that it might not seem as common in India as we do not encounter it often. But when we went through our case, we searched for other case reports and found that there were multiple such cases of histoplasmosis recorded in our country. As you can see, I've mentioned so many cases. There were cases of immunocompetent patients showing disseminated histoplasmosis. There were cases when it was found with another diseases like electroviral diseases with diabetes mellitus, hemophagocytic syndromes, and even with rheumatoid arthritis, which we found in our case, did find other cases also. As for the treatment, asymptomatic mild disease is usually self-limiting. There may be some incidental old granulomas found, and these all usually do not require any treatment. Treatment may last from 6 weeks to 12 months, even to 24 months in some cases. Immunosuppressed individuals usually require a lifelong treatment. Itraconazole is the first line of therapy, whereas liposomal amphotericin B is added for a severe case. As for the algorithm, in an acute case of pulmonary histoplasmosis, the initial treatment with intravenous liposomal amphotericin B, 3 to 5 milligram per kg of body weight, is given once weekly for almost 2 weeks of duration. The follow-on treatment is given for itraconazole, usually 200 milligrams, usually thrice daily for 3 days, then twice daily for a total of 10 weeks duration. Further, if the patient has a chronic pulmonary histoplasmosis, the treatment might continue for 12 to 24 months. Treatments contain of, again, itraconazole tablets, which are 200 milligrams twice a day for 3 days, followed by 200 milligrams twice a day for, as I said, 1 to 2 years of duration. In a disseminated case of histoplasmosis, if it is acute, we start the treatment with, because it's a severe disease, as I was already mentioned, we start with Ambisome, which is liposomal amphotericin B, intravenous 3 to 5 milligrams per kg body weight once daily for 2 weeks, followed by itraconazole 200 milligrams TDS for 3 days, and to complete the treatment for 1 year duration, we give itraconazole 200 milligrams twice daily. In the case of chronic disseminated disease, amphotericin B is suggested to be given 3 to 5 milligram per kg body weight once daily only for 4 to 6 weeks duration. This case was admitted under respected Dr. Seema in our hospital. This is a very special thanks to her for giving us the opportunity to present this case. Thank you everyone for this wonderful opportunity to me to present this case. Thank you so much.
Thank you, Dr. Atul. I think I would just want to add a few points to highlight regarding our case. Interestingly, considering the fact that this was disseminated histoplasma capsulatum, so the idea was obviously to start off with liposomal amphotericin B first, injectable, but then because of certain financial considerations, the patient and attendants, despite being explained the gravity of the disease, seriousness of it, took some time before they could plan admission. That's why the patient was had to be started on itraconazole first, because we didn't want to delay the treatment because of delay in admission because of financial reasons. Another interesting point was that when this patient got diagnosed because of the patient's bone marrow biopsy, we spoke to our hematopathologist, and he also took us through a very similar case. He told us that there was a previous case also pretty much similar historically, a case of rheumatoid arthritis, who had discontinued methotrexate, and then basically landed up, although the general condition in which the patient landed was much more severe, it was advanced disseminated disease, and they had found a reported histoplasma on the peripheral smear itself. But then, as we were very thrilled, both of us, Atul and I, when we had gone through this case, and I remember I had called RK sir to discuss about this case, and after that we obviously went through the papers and found that it is common in the Gangetic plains in India. But interestingly, we also found a few more things that basically, as already Dr. Atul explained, that this is basically a T cell, T cell acts a very necessary role in recovery from histoplasmosis. And what methotrexate basically does is that it enhances T cell apoptosis. As a result, I think methotrexate probably could be labeled the culprit in this case. And the other thing, like the literature, all those studies that publications that we had gone through, we were actually trying to understand and find out like which are the cases of PO, because when we go through character PO in, let's say, our textbooks and this thing, histoplasma is generally not something that probably pops up, or the not the initial few diagnosis that people come up with. So we wanted to go through and understand in this case basically, and discuss with everyone on such a forum regarding their experience with cases that they might have encountered. And what we figured out that most of these studies, just like our case, the points with which the patient presented are very typical, as in almost 85% of rather 85 to 89% cases, most of the studies quote, come with significant weight loss, and fever is present in 73% cases of disseminated histoplasma. And the other most initial common lab abnormalities are anemia and thrombocytopenia. And like going through these studies and looking retrograde, it feels like oh, it was quite a bummer, obviously, like these features, and why not histoplasma. But this is why we wanted to discuss this case. And again, I would like to thank definitely Spice Root, Dr. Atul, and RK sir definitely for this great opportunity. And I would request further comments from RK sir, and like questions also from RK sir, and then probably to audience questions.
Okay, hi. So, first of all, Dr. Atul and Dr. Vidyot, I mean, just fantastic presentation. It was so well researched, so well described. It was so instructive. Honestly, I learned so much by listening to you, and thank you very much, Atul and Vidyot, for doing such a fantastic literature review. And that map of India with the distribution of histoplasmosis was just fantastic. And so much to learn from this case. And thanks, Vidyut, for explaining why methotrexate puts people at risk of getting histoplasmosis, the T cell dysfunction that it induces. I think I don't have too many questions. I would love to hear from everyone else as to what experiences they have had with histoplasmosis, but I'll leave you all with three kind of learning points which over the last few years of practice, it comes back again and again. So the first is, you know, cytopenias, especially anemia, is very common. But bicytopenia and pancytopenia always suggest the need for thoughtful inquiry. So CBC, I'm sure all of you as family doctors or residents of family medicine see a CBC 20 times a day. But please make it a habit to circle the hemoglobin, circle the platelet count, circle the total leukocyte count. If you find bicytopenia, you have to look for some underlying process which may not be benign. So that's the first learning objective I want you all to take home. Second, when you come across bicytopenia or pancytopenia, please test for HIV. Just day before yesterday, I had a patient in my practice who had been admitted to the hospital, who had had 2 strokes in the last year. He had had pancytopenia for the last 1.5 years. He was under the care of a hematology oncologist who had done bone marrow biopsy, who had started fancy medications, started steroids, but they had not tested for HIV. So when the patient was admitted to our ICU, we just the ICU doctor ran a routine HIV test, and this patient had AIDS. All this, so what happens is in the diagnostic workup of a patient with pyrexia of unknown origin, or actually a whole host of presentations, syndromic presentations, ruling out HIV narrows down your differential diagnosis very effectively. And ruling in HIV leads you to some very specific thought processes and diagnoses. So please check for HIV because it will help you navigate the differential diagnosis. If you know HIV or non-HIV, you can look up any textbook or look at up-to-date or online, and you will find specific differential diagnosis. But if you don't know HIV, yes or no, then the world is wide open. The third point I would say is inter-specialty collaboration and the family medicine or internal medicine doctor thinking through is the most powerful diagnostic tool, which Dr. Atul and Dr. Vidyut, they have demonstrated so thoughtfully here. So if you don't think about it, you will not pick it up. The second thing is, when you suspect it, especially in bicytopenia, pancytopenia, a call from a family medicine doctor to the or internal medicine doctor to the pathologist and microbiologist goes a long way, because many times this is not something pathologists look at every day. So when you prime them and say, look, I have a patient with bicytopenia or pancytopenia fever, I'm concerned about a disseminated process. I do not know whether this is tuberculosis, lymphoma, leukemia, myelodysplastic syndrome, or some rare pathogen, which could be histoplasmosis, it could be leishmaniasis or Kala-Azar, it could be something else. When you tell that to a pathologist, he looks for this. And you have to tell the microbiologist similarly. See, what is unique about this, many of these fungi, this is a dimorphic fungus. What that means is, like Dr. Atul showed on the histopathology slide, it's a yeast at body temperature. In the bone marrow biopsy, when a pathologist looks at it, it's a yeast. But when you grow it at room temperature, it grows as a mold. These are important things. So a mold looks very different from a yeast. So I think these are the 3 points I would urge you to think about. And 4, itraconazole. See, fluconazole is a very common antifungal we use in practice. I'm sure most of you have used fluconazole. I am also sure most of you have used topical antifungals. But itraconazole, many of you might not have used, and other antifungals like amphotericin, maybe you've used, maybe not you've used, or posaconazole and others, isavuconazole, you might not have used. But itraconazole, please check drug-drug interactions. When with many common drugs, if you do these 3-4 things as a family doctor, you will deliver outstanding care. So with that, I will close my comments. Thank you so much, Dr. Atul and Dr. Vidyut. It was a truly pleasure and privilege. Thank you.
Thank you so much, sir. Thanks a lot. Really, some great points to, let's say, summarize, or practically, sir has laid down the entire presentation in 4 sentences for us. And after listening to sir's points, I suddenly recollected that just before this case, we had a patient who presented to us with cough, and elderly gentleman, ex-serviceman, and the patient didn't appear so toxic and all of these, and all we had on the peripheral smear was rouleau formation, and suddenly it was decided by our consultant to take a call and get a HIV test done for the patient, and the patient turned out to be HIV positive, and no history of blood transfusion, and no history wise, at least no promiscuous behavior or anything of that sort. But strangely, whatever he could say was that he had a bullet injury during his period of service, and that was the only reason for which he was hospitalized and treated. And previous I think in 1960s he had tuberculosis, but the current protocol does suggest that all patients of tuberculosis should undergo HIV testing. And I think what I recollected that HIV shouldn't give you the picture of AIDS complex always. The patient might not be so sick or toxic looking, and the idea is to, if we can catch a patient early, it benefits the patient obviously. So I think and even after the diagnosis, because it was equally shocking to the family also, like the patient himself, and then he was himself, he consented to disclose it to his family and this thing, and the family turned out to be very supportive, but it obviously takes long hours of counseling the patient and understanding, and thereafter the patient has been following up with us in the OPD, and the patient is forever grateful, and that he has been started on treatment before he develops any severe other infections or diseases. So yeah, I think that is what I remembered the moment RK sir suggested of getting HIV tests done for patients. So with that, if anyone has any questions that we can probably try to answer. I think participants can raise their hand or post the questions on the in the chat box.